and we are feeling proud to have him with us. Doesn't lose its sweetness. That's what Phil has with us. And appreciation is like a bone graft. You need it for a strong union. So we want to present a memento to him. My core committee.
Sir, इधर next विशाल sir, उधर आइए, उधर बगल में.
Core group of team members, and this is a gift which is made in Cawnpore.
All right, even better.
And the best thing is that this is made in Cawnpore, but for Hugo Boss.
Hugo Boss.
May I open it?
Oh, yes, you can.
I'm intrigued.
So there's a committed fan.
Last evening also.
You expected it.
I expected it also before getting it.
You may have got a lot of mementos, sir, but this is one thing from your use.
Oh, really? Even better. Useful things are always good. Well, gentlemen, thank you very much. Oh, wonderful. You've obviously seen my wallet.
No, I haven't, but we really discussed it among ourselves. Instead of giving memento, why not give him something and make it made in Cawnpore?
Well, that's really kind. Thank you. I'll tell you an interesting story. I was in Nigeria 6 weeks ago doing some knee surgery, and when I came out of the theatre, I had no belt in my trousers. Someone had stolen it. I just mentioned it casually to the surgeon. The next day, when we were in the theatre, before we started, he stopped. And he put this very stern face on, and he tore them to shreds about the fact that this visiting surgeon had spent all this time coming here, and they'd bought him, and they'd taken his belt, and then presented me with 3 belts.
Okay. So we have not taken anything. So it's only one belt.
Thank you very much.
It's a pleasure. Trying to prepone one case discussion first, if you all agree. So we have got one case discussion session, then lectures, and then again a case discussion session. Is it okay with you all? So many lectures which were supposed to be done now will be dealt later on. And can I request Professor VIth to start with his cases? And we have got eminent people from our own city. I hope Professor A.K. Gupta, please, you can join us on this case. A.K. Gupta is the head of the department of the same department from where most of us have studied, that is GSM Medical College. Professor Rajendra Nath, if he happens to be here. Professor Rajendra Nath, hey sir. Again, just before Dr. Gupta, he was the head of the department. Then we have got Professor S.S. Jha, who will be presenting a case also. Can you come on the dais, sir? So these 3 are from our own. Dr. Gadre, I think, 11. And then we have got professors. Professor C.S. Yadav, a great friend. Can you join us as a panelist? Because the cases will be shown and we would like to enlighten the delegates. Professor Anil Arora, sir, please. But it is open to everyone. You have it here. The cases will be open to everyone to discuss. So you may not be on stage, but yes, you are most welcome to give out your opinion. Because we have got the stalwart from our own state. K.T. Tripathi has come from Allahabad, Anup Khare is there, Saurabh Shukla is here. So we have got it. Yeah. Okay. So long the power is coming. The idea is to show different cases, how it has been solved, and there are many doctors among us who will be showing their cases. Dr. Okay, that's it. Anup Khare was supposed to, you have got a case on knee. Yes. Dr. Anand Tiwari will present cases on knee. Anyone else who has got any interesting case on knee? You have got a case? Your name, sir? Okay, so fine. So these are the 3 cases after Phil has shown his cases. These are the 3 cases Dr. Vishal will coordinate and Call him on my Okay, really name. So, yeah, you have already have got one godfather here, right?
Right, gentlemen. I thought I'd show you 3 or 4 cases, and I'd like to know what you can do, and I'll show you what I do. They're not particularly exotic, but they illustrate things that I've learned in orthopedic surgery. Right. So let's see what you think. It's not unusual. What issues with the Who's this? 71-year-old woman. Why have we got no video?
Show the pelvis X-ray also.
Don't have it. There's nothing dramatic on the pelvis.
I'll use PS implant, I think.
Why are you using a PS?
I'm trained to and I'm to do that.
Okay.
Using a PS knee,
Well, you will have a large flexion gap if you cut the PCL. So
that's right. And
yes.
I will use CR implant because patient is already 70 osteoporotic. I will try to avoid that notch cut.
Okay, that's a reasonable thing as well. Would you feel need to put any constraint in this knee?
No, I don't think so.
Okay, would anybody?
But if you keep it at not very good, and pushing if you were
Like this, like this.
I'll keep a TC3 handy
Because?
because I might experience mid-flexion instability, might maybe the flexion gap is more, I might not be able to balance it properly. It's almost 25-30 degrees of balance.
Yes. Okay.
I feel whatever implant you use, you need extension rod for this case because both looks to be very osteoporotic. And I can see in the lateral view, the posterior femoral condyle structure is not there.
So these are the cases where CT is must. I think we talk a lot about CT in the THR. But why not CT? We get the proper CT. That's what I'm saying.
Okay. So do a CT and see what that shows. I mean, we see this occasionally. This is osteonecrosis. We see idiopathic osteonecrosis in the knee. It's not common, but it's the commonest cause of osteonecrosis in the knee in our patients is idiopathic. Actually, no, it's not. It's idiopathic. Fewer steroids. There's very little else in the knee. And actually, most of the osteonecrosis we see in the knee is self-limiting. It gets better. But every once in a while, we do see patients that require an implant.
Now, what is the range of motion of this patient before?
I can't remember, but she would have had about 110.
So it's all mobile knee?
It's a mobile knee, yeah.
can I ask some more?
I'll show you what I did do.
How is the opposite knee?
How soft? Not too bad. We don't. Osteoporosis, osteopenia in British patients is not the issue that they have in India. We don't. We even in what you think is pretty osteoporotic bone is actually pretty good most of the time.
I'm not pointing out osteoporosis. Was she rheumatoid?
No.
Not rheumatoid?
No, not rheumatoid.
How about other knee? Was it deltoid?
No, it wasn't. It was reasonable. It was mild valgus, but not this degree.
Yeah,
I think she's developed this as time has gone on. You can see on the lateral side is a little screw, and we just fixed a bone graft into that area just to give it a little support on the lateral side. But otherwise, just a standard tube. And the correction of this deformity wasn't a problem. There was a little bit of flexibility on the table, and you often find this in valgus knees. When you assess it on the table, you can correct it, sometimes quite more than you think. So you don't need a huge soft tissue correction. And that's with a standard 9mm insert. So the medial side wasn't particularly stretched. It was just a reasonable need to do. No, sorry, I'm not making it easy for you. No.
Inflammatory arthritis, number one, or any dysplastic pathology. development.
Okay. The one clue I'll give you is a man.
It's like
It's not rheumatoid disease.
Station, how's the station?
It's okay. This is hemophilia. This is hemophilic arthropathy. We are the second largest hospital in the UK for management of haemophilia, and my job was to manage the haemophiliac patients. So I inherited, when I first started, I had a whole bunch of patients like this with these deformities and this sort of disease to manage. So, what issues do you think there might be with handling this patient, both surgically and medically?
Now it's hemophilia.
Well, the physicians look after that for me. Anything else?
Difficulty in balancing. I'm a PS surgeon, so I don't find much difficult to balance the PCI. Second,
Well, I'm a...
correctability of the deformity, how is it in place? Margin,
No, it's really rigid. Yeah.
quite stable otherwise.
Any other issues there?
Exposure,
Yeah.
you might need eye loose snipping,
Yeah.
you do tubercular
And that's fair enough. This will be a tough exposure, they're always very stiff.
That's right.
Flexion development.
And in lateral view, I can still see some cleavage, though not very clear. Do I find it's I think 20 to 50 degrees, no? Range of movement is 20 to 50 degrees.
No,
Yes, it is mobile.
There's it
Some
is
is
mobile,
mobile.
but not much. It's this bit. Yeah.
So I'll do a conscious today.
Okay.
One needs to gradually
What
mobilize.
what about planning this procedure? What will you want? You said you're going to put a PS knee in. Do you want to think about anything else?
I will avoid using usually non-spot jig as jig.
Say again?
I will avoid using intermittent jigs. I think the computer assisted is CAS is.
You use CAS.
I won't use
Okay.
intermittent jig.
Okay. We didn't have CAS when I did this knee, so that wasn't in the equation. And I don't think CAS is needed actually.
So you can not projection is what typically needs, but do we have seen our condyles, what is the anatomy there?
Well, if you look at these X-rays, there's significant bone loss.
Yeah, because lateral side and a lot of bone loss.
And that becomes an issue when you're dealing with knees like this. To do something with these defects, you've got to support them in some way. And this is the one, these are the sorts of knees where you really need revision type implants to be able to cope with it. The other big problem with these patients in my part of the world, and if you put constraint into a knee replacement, either primary or revision, with something like an LCCK or a TC3, you have to stem the tibia and the femur, because the forces acting on the interface are much higher with a constrained knee. If we look at the other knee, because I've used a wedge medially on the tibial side, then we've used a stem anyway, but we've stemmed both sides. So you dial constraint into your knees, you must change the interface. Don't rely on a primary one as your interface, because they do fail.
Basically, we have hemophilia clinic in our institute. We got a lot of hemophilic patients. So I have done more than a dozen hemophilic knee within 3 years. And most of the situation, we use PS knee, simple PS knee, sometime extension brought to the tibia. Because
it's not the haemophilia that decides it, it's the bone loss in this particular case that decided it.
was there any need of putting a stem in the femur?
Because I put they had distal augmentation, so we had to put distal femoral bone metal blocks in to get the joint line down to the right position. Therefore, we stem the femur. Anytime you augment a femur or a tibia, you should protect it with a stem, because the interface is not as good as with a standard implant. 2 more cases. This lady is 40. She's got rheumatoid arthritis, I'll give you that. She's had ankylosed hips and knees in full extension for 20 years. She's had a femoral osteotomy at some stage in the past, we're not sure when. And These are her pelvic x-rays, and these are her knee x-rays, just the laterals. The APs are straight, but she's got ankylosed knees in full extension, she's got ankylosed hips in full extension. I got the story because a surgeon in her part of the world did this hip replacement, which is an interesting hip replacement when you look at the lateral. But it gave her a flexible hip, and suddenly her outlook changed. She's been bed-bound, wheelchair-bound for years, and suddenly she can move one leg, so she wants the other one doing. So I did the left hip here, that charmed it, I did. So she's happy now, she's got 2 flexible hips, but now she wants her knees doing. She has no pain at all. She just has ankylosed knees in extension and says, you've done my hips, please do my knees. So what do I do? Okay? We tried that, we dissuaded her. I tried everything I could to persuade her.
I think you should
this
do
was not a
one
good idea.
I think you should do one knee.
Okay, my major issue was, what can I offer her in terms of function? I had no experience with this, no idea what she would get. My colleague said to me, well, she may get 30 or 40 degrees of flexion, but it might then be painful. Is 30 degrees better than 0? I think it is. I think if you've got even a few degrees of flexion, it makes sitting a bit easier, it makes other daily activities a bit easier. Would you agree with that? So does that change your mind? Do you want to do it now? Who would like to take this knee down and replace it? Wow! A hero!
See, bilateral is different story. I was just joking at that time, but we have done it.
We didn't do it as a bilateral. I've got the AP, she is very parotic. So I've used a cemented stem on the tibia. And we did her other knee about 6 months later, I think. The reason I put this in, because I was surprised at the result. I really wasn't expecting this. And that persuaded me that ankylosis, at least, is probably a good condition to treat with knee replacement. Because we had great problems with doing arthrodesies converting to knee replacements. They almost universally did badly. That was our experience. But ankylosis, I think, is completely different. Last case.
Can I ask you one question?
Yeah. Oh no, not last case. Yeah.
Majority of these cases, when I stuck to the femoral part, how do you
You take a broad osteotomy. You can see the line where it's stuck onto the femur, and you just gently tap it across to the fracture. In fact, the exposure is not as difficult as you think. Sorry, I've got 2 quick ones. This man's 56, severe knee pain. So what are the issues here? Okay, is that a problem? Is it going to stop us doing a knee replacement? Well, he's got patellofemoral away, so yeah. So, is this deformity going to stop me doing a primary total knee replacement? Sorry? So you're going to correct the deformity first? How are you going to do that? Okay. Opening wedge, closing wedge. Close wedge. How are you going to fix it?
With the plate.
With a plate, list plate, something like that. It's femoral plate. Are you going to do it at the same time as your knee replacement or staged?
You can do in the same sitting.
You can do it in the same sitting. So you do it in the same sitting? No. Oh yes, I'm sorry.
Yes.
Yes.
I feel if the deformity is less than 16 degrees, you can do intra-articular correction.
I would agree with you. This measures about 30. This actually measures about 30.
I would like to go for computerized use navigation technique.
Okay. To do the osteotomy or to do the knee replacement?
We have not limited.
No, we haven't, but this deformity actually measures 30 degrees. Yeah, well, do you know what the magic figure is for that? Of deformity? It's 15 degrees. 15 degrees close to the knee, that's the point at which you struggle to correct within the knee. And it's really important to measure it. So don't just look at it and say this works, but measure it.
And second problem is patella tracking, which is subluxed.
Yeah, well, it's a valgus knee, isn't it? Effectively. This patient's Q angle is going to be extreme because of the deformity. So that will affect the patella tracking. So I'm going to plate it and total knee at the same time. Does everybody do that? Yeah? Everybody happy with that? Okay. Well, we didn't, of course. But, the key to this is to plan it before you start. So take your x-rays, template it, work out the correction, work out the wedge, and off you go. So this is the case. There's the opening wedge. Okay? That's then fixed with a couple of K wires, just to provide stability, and then the femur shaped to produce for the femoral component. We fix this with a sleeve. We use these in revision surgery, particularly on the femoral side, well, particularly on the tibial side, we have femoral revision sleeves. These are a nice shape, so they control rotation beautifully. And this